All right, thank you everyone. This is my first time speaking at the PH Summit, so I really appreciate everyone being here. Yes, thank you. So the objectives for today's talk is really to learn the evolution and current strategies we have in risk stratifying patients with pulmonary arterial hypertension, and understanding what tools we have to help risk stratify them. And finally, learn how using these risk assessment tools that we now have to help guide treatment and management. So this talk is going to be a pretty big topic to really help review how we treat the patients. So as everyone here knows, pulmonary arterial hypertension is a disease defined as progressive remodeling of the pulmonary arteries, which results in rising pulmonary arterial pressures and eventual right ventricular failure and collapse. So it shouldn't be a surprise that there's always been an early interest in risk stratifying patients. In other words, which patients have good prognosis and which ones have poorer prognosis. And this paper actually, about 3 decades ago by D'Alonzo, was one of the first to really shed light on this risk stratification of PAH patients. And I want to share a quote he says, and he said, "Treatments used late in its course, such as prostacyclin infusion and heart and lung transplant, are expensive and of limited availability. Now, these factors necessitate some form of priority assignment for these patients, and prioritization is based primarily on prognosis and severity of disease." So in other words, at the time, almost rationing treatment for those who need it most with poor prognosis. And you could see at the time, prognosis was very poor, with a survival of about 40% at 5 years. And what they found wasn't really shocking, but those with worse hemodynamics, specifically mean pulmonary artery pressure, mean right atrial pressure, and mean cardiac index, had a worse survival than those with more favorable hemodynamics. But a lot has changed in the last 3 decades, right? We have a lot more treatment options for our patients, and this is based on the fact that our understanding of the pathophysiology has grown. And a lot of these treatments now target these fundamental pathways, that being endothelin, prostacyclin, and nitric oxide pathway. So I frequently get asked by, not only that, but these treatments come in different shapes and sizes. This is actually comes from Dr. Marin's paper. You know, our treatment comes in oral, IV, subcutaneous, inhaled. So I frequently get asked by patients, and actually more so my colleagues, with all these treatments available, how do you know which treatments to give it and when? Well, just like any other disease, those with a poorer prognosis or those who are sicker tend to get more aggressive treatment compared to those that have a more favorable prognosis, such as low risk versus high risk. And I'll be using these terms, with intermediate risk being in the middle. So now in today's era of pulmonary arterial hypertension, how can we tell whether patients are high risk or low risk? Well, in 2015, the European guidelines proposed a multidimensional risk stratification model, as you can see here, using a variety of clinical, hemodynamic, and imaging parameters with different thresholds. And it kind of broke them up into 3 strata, which is low risk, intermediate risk, and high risk, with high risk having the highest mortality of greater than 10% at 1 year. Now, in the years to follow, several registry-based studies showed that simplified versions of this European model can be used as a reliable prognostication tool to help predict outcomes for patients with pulmonary arterial hypertension. And these registries include the Compera, the Swedish, and the French registries. Now here you could see, this is the Swedish and Compera. They used a similar, almost summation model, looking at limited variables used or proposed by the European guidelines, specifically functional class, 6-minute walk distance, proBNP levels, and various imaging and hemodynamic parameters. And what they did was they assigned a numerical value for each risk strata. In other words, if you met any variable from the low risk column or parameters, you got assigned 1 point, intermediate 2 points, and high risk 3 points. And you simply added up all the values, you divided them by the number of variables used, and you got a number and you rounded it to the nearest number. And the definition of low risk was an average score of less than 1.5. And you could see here, by looking at these graphs, we're looking at time versus survival, with time being on the x-axis and survival being on the y-axis. You can see that patients that met the low risk profile, which is seen here in green as a green line, had the most favorable prognosis and with good discrimination compared to those with intermediate or high risk. And this is both at baseline and at follow-up visits. Now, the French registry did it a little differently, a little simpler, which I like, in which they risk stratified patients not by adding or anything like that, but just by matching the number of achievements, or they looked at patients that were able to achieve a certain number of low-risk criteria that were met, recommended by the European guidelines. And you can see the low-risk criteria that they were looking for were functional class, 6-minute walk distance, right atrial pressure, and cardiac index. And again, those patients who met all 4 low-risk criteria, as in green, had the most favorable prognosis compared to those that had 3, only met 2, 1, etc. And this is both at baseline and follow-up. Now, they took an even simpler approach and more convenient approach, looking at a non-invasive model, looking at 3 non-invasive low-risk criteria. And again, patients that met all 3 non-invasive low-risk criteria, which was functional class, walking distance, and this time pro-BNP levels, had the most favorable prognosis compared to those that did not. Now, what all 3 registry-based studies show that's really important is it's not necessarily the absolute risk profile that was met, but the change in risk profile. In other words, patients that were either stable or improved to low risk profile had the most favorable prognosis compared to those that stayed in the intermediate, high risk, or worsened. So this really kind of reinforced or emphasized the fact that now we have some goal-directed treatment in which our goal should be for patients to achieve this low-risk profile with our treatment. Now, another registry did it a little bit differently. This is the American REVEAL registry, in which they looked at proportional hazard multivariable analysis, you can see here on the left, in which they looked at, again, a number of variables used, and they were able to derive this risk equation, in which came up with this 5 risk strata that you see here. But over time, this was actually able to be modified to this REVEAL 2.0 risk calculator. And again, similar to other models, you could see that it uses a number of clinical and hemodynamic variables, including the etiology of the pulmonary hypertension, demographics, functional class, vital signs, and so forth. And now this model, or this calculator, also use these kind of weighted variables in which those that are associated with worse prognosis had a higher value compared to those that had a more favorable prognosis, which actually was actually protective in a way. And you simply add up all the variables that and their values, add 6, and you get a risk score. Now, I want to just point out that the REVEAL calculator introduced 2 additional variables that were important, and that is chronic kidney disease and all-cause hospitalizations, as this has been associated with a poor prognosis, and so they included this in the risk calculator. And you could see here that the REVEAL risk calculator, again, resulted in good discrimination in prognostic outcomes, in which those who scored a 0 to 6 were considered low risk, 7 to 8 intermediate risk, and 9 and higher were high risk. And this, again, good discrimination, both short-term at 1 year and long-term at 5 years here on the right. When compared to the European models, actually looking at the ROC curve, you could see that the REVEAL 2.0 actually had a higher discrimination value with a C index of 0.76, again, compared to the other models. Just recently, the authors kind of revised this, making it a more convenient abridged calculator called the REVEAL Lite 2, in which what they did was, again, using that same calculator model, they just looked at the modifiable variables. You could see here in the top right, functional class, presence of renal insufficiency, vital signs, 6-minute walk distance, and pro-BNP values. And you could see on the right that the REVEAL Lite actually also discriminated well between low risk, intermediate risk, and high risk compared to the REVEAL 2.0 calculator on the left. Now, I'm going to do something that I don't think has ever been done at the PH Summit before, and that is pull back the curtain a little bit and break the fourth wall. And I'm actually showing you a clinic note of one of my patients last week. And this was a patient who came in She, was able to nowadays look at her EMR, saw that her RVSP was higher, and she freaked out. She came into office thinking that we were going to have to start new therapy on her. What's her prognosis? And she was extremely nervous. And literally, this is my note. And in my note, I have the reveal calculator in it. And you may not be able to see it. There's also the French, the non-invasive French model. And I literally turned the computer around, and I showed her that she had a lot of favorable variables and parameters. She had a good 6-minute walk distance. She had a really low pro-BNP. She met all 3 low-risk variables of her the French registry model, and I just reassured her that there's nothing that she's still doing well and that we're going to continue current treatment. But the same is vice versa, right? So if I see a patient in clinic who's very hesitant about escalating therapy, I turn the computer around and I just show him the risk calculator that we use and show him that he's either intermediate risk profile and that more therapy is needed, again, to get him to this low risk or get her to this low risk, all right? So now there's only one thing that's more exciting than breaking the fourth wall, and that's showing you guys the new guidelines, right? So this just came out a couple of months ago, in which there are updates to the new risk stratification model that they have, and here it is. And I want to just point out a couple of changes when compared to the old model back in 2015. And the one thing is that when looking at registry data, it turns out we may have underestimated mortality in high-risk patients. And so what they did was they increased high-risk mortality, 1-year mortality, to greater than 20%, and broadened the mortality of the intermediate risk strata to 5 to 20%. They also introduced a number of other imaging parameters, including TAPSE over SPAP and echocardiography, as well as some new cardiac MRI findings and hemodynamics, specifically with the introduction of stroke volume index. As stroke volume index has been shown in multiple studies to actually be a good prognosticator for pulmonary hypertension, with a lower stroke volume index being associated with a poor prognosis. Now, another important update that they did involves this intermediate risk group. And they did this for a couple of reasons. One is that you could see the broad range in mortality in this group of 5 to 20%. Another thing is that when looking at the registry data, about 70% of the cohorts were in this intermediate group. And even at follow-up, it was almost 70%. So there's a lot of patients that we treat, not only in the cohort, but that we treat that just remain in this intermediate risk group. And what do? Well, what they did is they recommended further risk stratifying within this intermediate risk group using this abridged variable model, in which they looked at functional class, 6-minute walk distance, BNP, and they broke up this intermediate group into intermediate low risk and intermediate high risk based on these revised variables. And so why did they do this? Well, this is based off of studies, one being the Compare 2.0, which showed that using this refined 4-stratum risk assessment tool had better discrimination at predicting prognosis, specifically within the intermediate group, and with an increased sensitivity at follow-up compared to baseline. Here's a really nice Sankey diagram. I'll admit this is the first time I've actually come across this diagram, and I think it's beautiful because it really demonstrates the point here. So you can see on the left is the 3-risk strata model, with green being low risk, yellow being intermediate risk, and red being high risk. On the left, you can see the baseline, and then what it does is it shows you the number of patients that actually changed risk strata at first follow-up. And again, proving that point, you could see with the 3-risk model that the majority of patients stayed intermediate. But with the 4-risk model, which is the Sankey diagram on the right, you could see a lot more diversification and better prognostication, or I should say better discrimination, when you divide these patients up into this 4-risk model. This actually was further validated looking at the French registry, in which they did an external validation using this refined model. And you can see the top 2 graphs on the left, and again, we're looking at survival over time, is using, the top 2 are the 3-risk strata model, with the left graph being baseline, the right graph being follow-up. And you can see compared to the 4-risk strata which is the bottom two graphs, that there was better discrimination and better prognostication, and specifically for that intermediate risk group. So now with what I've told you, with all this risk stratification, which seems like a lot, how do we incorporate this into how we treat our patients? And I'm going to talk about a couple of other things, but I promise I'm going to really pull into what we were talking about and why risk stratification is really important. So we're going to go through the new treatment algorithm proposed by the European guidelines, and it looks very overwhelming, but we're going to go through it in a step-by-step process. So first, you diagnose patients with pulmonary arterial hypertension, which obviously involves a right heart cath. And patients with idiopathic, hereditary, and drug-induced pulmonary arterial hypertension, these patients should all undergo vasoreactive testing, which includes inhaled nitric oxide. And if they have this positive vasoreactive response, defined as a decrease or change in mean pulmonary artery pressure greater than 10, an absolute decrease of less than 40, and a stable or improved cardiac output, these are patients that are considered positive vasoreactive responders. And this is important because a study by Sitbom back in the day showed that people that met this hemodynamic response may actually be candidates for calcium channel blocker therapy and have a favorable prognosis with long-term calcium channel blockers. But not all responders are long-term calcium channel blocker responders, which I know may be confusing, so they need to be followed up. But for the rest of the treatment algorithm, I'm going to basically talking about non-responders, which is the majority of patients with pulmonary arterial hypertension. And irrespective, they should all be treated with just general measures, including diuretics, pulmonary rehab, oxygen if they need, make sure they're up to date at immunizations. One thing that they really updated here was this concept of iron deficiency anemia and making sure this is ruled out and treated if it is indeed present. Now, when going on to treatment, one of the first things you should do is to really recognize if the patient has any coexisting comorbidities that may make them kind of higher risk for pulmonary vasodilators. We're talking about patients with left-sided heart disease, AFib, HFpEF, valvular heart disease, patients who are older, or patients that have parenchymal lung disease. And so if there's any concerns about tolerance, what you'd want to do is start on monotherapy, which I would probably, in my practice, I use PDE5, such as sildenafil or tadalafil for these patients, and then follow up to see how they're doing. Now, if the patients don't have any concerning comorbidities, this is where you risk stratify these patients at baseline. And this is where using that risk 2.0 calculator or either using European models really comes into play, and to really risk stratify how your patient and what risk strata your patient is in. Now, if your patient is low or intermediate risk, the recommendation is to treat with combination PDE5 and ERAs. And this stems from the infamous AMBITION trial, which showed that combination ambrisentan and tadalafil has resulted in improved clinical outcomes compared to those that were treated with monotherapy. Now, if patients are high risk, the recommendation would then be to start up with upfront combination therapy as well as a parenteral prostacyclin. Again, it's important to follow these patients up, and so your next follow-up visit is when they recommend using this 4-strata model, or this abridged version 4-strata model. Again, if patients are low risk, this is what we want, so you continue current therapy. However, if the patient is intermediate low risk, that's when you could add an oral prostacyclin, whether it's a prostacyclin receptor agonist or an oral prostacyclin analog. One other creative way you could do is actually switching patients from PDE5 to riociguat and soluble guanylate cyclase, and this is based off of the REPLACE trial, which was just recently published, in which that showed that when switching patients that were originally on a PDE5 to riociguat, is that there may be improvements in 6-minute walk distance, functional class, and pro-BNP, as well as a trend towards improvement in time to clinical worsening. And again, if patients meet the intermediate high or high risk, that's where you want to, again, escalate therapy, but potentially be more aggressive with parenteral prostacyclins. So what's really important if you want to manage these patients is follow-up. These patients need constant follow-up because this is where you constantly reassess what risk strata they're in. So this is just kind of a generalized template. You want to get echoes maybe every 6 to 12 months, 6-minute walk test and BNP every 3 to 6 months. And again, every visit, when I see these patients, is you risk stratify them, and this kind of really judges how you're going to manage them. So again, here, I'm going to leave you with this, where those with high risk tend to get more aggressive treatment. But again, the treatment goals, if I want you to walk away with anything, is to really treat these patients so they get into these more favorable risk profile of this low risk. Finally, I want to just spend some focus, just because I do have an interest in palliative care, is that I just kind of haphazardly brought up about, when these patients are high risk, we start them on parenteral prostacyclins like IV or sub-Q. Well, if anyone's treated these patients, right, it's not that easy. Patients have fears, patients have concerns. I've had patients that all they want to do is swim in a pool. And so it's not that simple, even though it's one line on this treatment algorithm. And to remember that patients, that when we're following just symptoms and exercise and biomarkers, to not forget that we're actually treating people that are worried, people that have a lot of anxiety. And so just making sure that when we introduce these aggressive treatments, is this best for the patient? And making sure that we don't make it overwhelming, but kind of reaching that kind of balance. So in summary, both the European ESC and ERS and REVEAL guided risk assessment tools are simple and easy ways to estimate mortality risk in pulmonary arterial hypertension patients. And treatment goals should be oriented at achieving low risk parameters. Close follow-up with ongoing assessment of risk parameters is fundamental in the management of these patients. And again, most importantly, is treatment should always be individualized to the patients, because we are treating people, not just values. So I want to end there. Thank you guys so much.
Anthony, that was amazing. Any burning question for Anthony? I have one. So how do you think about these scores, REVEAL and the French approach, in our sort of mixed pH patients with comorbidities and so forth? I always struggle with that, in terms of, some of these things are not modifiable, maybe the knees are terrible and that's why they don't walk.
Yeah.
So I wonder if you can share with the audience a little bit about how you adjust these scores to particular patient populations.
Yeah, well, I would say, yeah. So I don't know if I'm going to answer this question. It is complex. I think patients with underlying, if they have pulmonary arterial hypertension from another class, such as patients with interstitial lung disease or coexisting left-sided heart disease, I don't know really how to kind of use or use these risk models, because again, these models weren't really shown to these people. But to answer that second part, that is a frequent occurrence where you see patients that say, my knee was bad, and so my 6-minute walk distance decreased by 100. A lot of these risk models, they took into account that you don't necessarily need every variable. So what I probably look at the whole big picture. I look at how the patient's feeling. I look at the pro-BNP levels, and just the echo. So I look at kind of multiple variables and not just taking one into consideration to kind of decide, is this patient still functional class 2? And maybe he just had a bad day. Is the BNP not accurate? So I don't put so much weight on one variable. I take kind of the whole picture and try to make the best decision, but it is difficult.
Okay.
Thank you.
Thank you so much, Anthony.